Okay, welcome to our lecture today on the urinary system. So the urinary system is your major excretory system. It's the system that removes waste. It's the most obvious, actually, the most obvious system that is removing waste in the form of urine. And if you look at this urine, it's going to tell you a lot of stories. You're going to find in the urine acid. You're going to find in the urine metabolic waste. You're going to find in the urine metabolic byproducts. When we metabolize the proteins that we eat, what do we metabolize the proteins into? We metabolize the proteins into ammonia, and then we're going to metabolize it into uric acid. Then we also metabolize the nucleic acids. And we metabolize the nucleic acids that are going to come out in the form of creatinine, in addition to in the form of creatinine and in the form of uric acid. So uric acid is a metabolic byproduct of breaking down nucleic acids. So remember, acid goes with acid. So you need to know that. You need to know that when we break down nucleic acids, we get uric acid. And when we break down proteins, we get ammonia as a first step. But ammonia is really, really, really toxic. Very bad. So your body is going to metabolize ammonia into urea, which is bad, but not as bad as ammonia. So the top two are a metabolic byproduct waste that is generated from breaking down what? The top two, ammonia and urea, are made from the metabolic breakdown of what? Proteins. While the bottom two, uric acid is the metabolic byproduct of what? Uric acid is the metabolic byproduct of nucleic acid. Remember, I said acid goes with acid. Nucleic acid, uric acid. While creatinine is also a metabolic waste that is a dumbed down product of creatinine phosphate. Creatinine phosphate is really toxic. So when we study metabolism later on down the line, you're going to learn that metabolism involves not only generating waste, containing waste, preparing waste to be properly disposed away and removed, but it also involves making something toxic less toxic. As what we saw here, ammonia is terrible. Ammonia in your body will kill you immediately, but your body is going to metabolize ammonia into urea, which is also waste, also toxic, but definitely not as toxic as ammonia. So that is found in the urine. But you know, when I began the lecture, I said that this urinary system is a system of excretion. And we reserve this word excretion to bad things. You don't excrete good things. So that's why we say secreting sweat, secreting enzymes. We don't say excreting enzymes. We don't say excreting sweat because these are beneficial things. Sweat is beneficial for your thermal regulation, and your enzymes are important. So we say they're secreted. So if you are oozing out or squeezing something beneficial, that's secretion. But if you are squeezing or oozing out or bringing out something that is really nasty and toxic and waste, that is called excretion. So the urinary system is an excretory system. Is it the only excretory system? Is your urinary system the only system that is responsible of removing waste from your body? So what else? Your lungs. Your lungs, very good. So what we did last week, your lungs are responsible for, or we say as a whole, your respiratory system. Your respiratory system is responsible for expelling, shunting, and removing carbon dioxide, which is a very dangerous waste. So what is a waste? Waste is anything harmful or anything that is not harmful but exists in more amount than it should. So oxygen is obviously beneficial. We need oxygen for aerobic respiration. We need oxygen for oxidative phosphorylation. But now too much oxygen now, that's gonna be a waste. Toxic. So your respiratory system, very nice, is one of your expiratory systems because it's responsible of shunting, exhaling carbon dioxide, protecting you from over accumulation of carbon dioxide in the body. Why is too much carbon dioxide in the body a bad thing? Why is it toxic? Yeah, you can do when you have carbon dioxide, why is it bad?
You can't do oxidative phosphorylation.
Right, you cannot do oxidative phosphorylation, but its mere presence, too much carbon dioxide in your body. Why is that a bad thing? It's just mere presence of carbon dioxide. If there's too much carbon dioxide in your body, what would that lead to? If there's too much sugar, that leads to diabetes. If there's too much cardiac output, that leads to hypertension. When there's too much carbon dioxide, what does that lead to? So carbon dioxide, what these issues are. This is not language of credit. Issues. My grandma would say that. You know, she would say there's issues with our respiratory system. They're being specific. So COPD is when you are inflating the lung, but you have an obstruction, you cannot get it out. Too much carbon dioxide, you say, is going to be converted into carbonic acid. Acidosis, very good. So too much carbon dioxide is going to be converted into carbonic acid. Now, when you have too much acid in your body, that's going to lead to acidosis, which is going to destroy it's going to deviate the pH of the normal homeostatic pH. So we don't want that. So our respiratory system removes this carbon dioxide to help us protect us from acidosis. So does the urinary system. So the urinary system also protects us from acidosis. How? Because if you have too much acid in your body, your urinary system is gonna pee out, is gonna urinate out this acid in the form of hydrogen proton. This is really, really important. Your urinary system is gonna get out hydrogen proton. So why do we not want too much hydrogen proton? Because too much hydrogen proton is gonna okay. So how about this? We're gonna be having quiz next week. So every week, either exam or quiz. Okay, so that we warm up. But it's still gonna be off of the question that I'm gonna give you. So the same way, we're gonna choose questions off of the exam. There's gonna be questions off of the homework for the exam, questions off of the homework is gonna be on the quiz also. Yeah.
Is it alternate? I would go around taking it early. I'll take it.
Okay, so talk to me about a personal thing, like private.
Okay, please. That's. I was also
Yeah.
talk to you about that.
Yeah, so you do that. Okay. So now we mentioned two expiratory systems, your urinary system and your respiratory system. Are these the only two that excrete the waste? or your respiratory system and your urinary system, the only two systems that remove the waste? Of course not. What's the third one? So you only go to the bathroom to do number one. So that is your digestive system. So your digestive system is responsible for excreting all of the waste. So those are three systems that are responsible for getting rid of all the bad things. Otherwise, toxic things are going to be building up in the body. So today we're going to talk about the first one, which is the major one, the most major one. So before we look into the urinary system, we have to see what is it made up of. The urinary system is made up of two kidneys, two ureters, one urinary bladder, and a urethra. Two kidneys, a right and a left kidney, two ureters that connect the kidney to the bladder, and one urethra that voids the urine from the bladder. Is that clear? Okay, now when we look here, we see that these two kidneys are not like your ears. So your ears are lined up properly. No ear is down and one is up. But your kidneys, they're not like that. The kidneys, they cannot be both of them like your ear lined up. One is a little depressed. Can you tell which one is a little depressed? So that's the anatomical position. You always remember from AMP1? Yeah, the right. Very good. So the right kidney is a little bit more depressed down compared to the left kidney. There's got to be a reason for that. There's got to be a reason for that. The reason is the liver. So the right lobe of the liver is pressing down, on the kidney, the right kidney, bringing it a little bit down. Is that a problem? Does that affect the function of the kidney because the right kidney is depressed by the liver and it's a little bit down? Does that mean the right kidney is not as good as the left kidney? Not at all. Does it function perfectly? But that is important. Why? For radiology. So that when the radiologist is looking for the CT scan, for the X-ray, is not going to be shocked. Say, why are they not aligned? Also, when we do the reproductive system, you will see that the male testicles, they're not aligned the same. You will see that for the males, the right testicle is a little bit depressed more. So we will get to that when we do in the reproductive system. But these are all very important features. But you need to know that. Right kidney, a little bit depressed. You have two kidneys. You don't have three kidneys. And you have ureter and a bladder and a urethra. So what are the functions of the kidneys? That's very important. They filter. So all the blood. The kidney weighs about 0.4% of your weight. If they weigh all of you, how much do you weigh? And you take out the kidneys and weigh them, the weight of your kidney compared to the weight of your body is 0.4%. Now the issue is this 0.4% is getting 21% of your blood. That's like the upper 1% making 90% of the income. You heard something like that. So what does that tell you? So the kidney receives about 20%, 21% of your blood. How much is that? 20%. $20 out of 100. How much is that? That's 20% of your whole output, cardiac output. Is the kidney taking all that blood for itself, for its own good? No, It's because you want to filter it. It's filtering this 20% of your blood. So you need to know these functions. That it filters blood, and when it filters blood, it separates blood into two separate two rivers. One river is going to go back into the circulation, your actual blood, and the other river is going to go out into the urine. So it receives one river, your blood, and it's going to separate it into two. One is bad waste, and the other one is good blood that's going to go back to the body. That's why people who are doing dialysis, that's why people who have kidney failure, they cannot make urine. So their blood is really, really, really toxic all the time. Their blood is very, very toxic because they lost capacity to filtrate. So they go to the machine, the dialysis machine, and the dialysis machine is going to, on behalf of their kidneys, filter blood for them. Regulate blood volume, pressure, and osmolality. So we need to have the kidney is not just to make the urine. Kidneys don't just remove the waste. Kidneys control blood pressure. How is that? Well, you remember one of the ways we control blood pressure is what? Is the blood volume. Remember we said cardiac output? Cardiac output equals heart rate multiplied by stroke volume. So if the blood volume drops, what do you think is going to happen to the cardiac output? We talked about this in shock. If you sweat too much, or if you get a gunshot wound or a stab wound and you lose too much blood, what's going to happen now to your cardiac output? It's going to drop. So how can the kidneys do that? Drop blood pressure, increase blood pressure. By urine formation. So if your blood pressure too high, they make you pee a lot so that your blood pressure goes down. And if your blood pressure is already down, you're drowsy, they're gonna hold urine and they're gonna take water from the urine, put it back into the blood. So you see the kidney is constantly shuffling based on your need. That's why we get diuretic. You know diuretics? Diuretics is for patients who have high blood pressure. They take the diuretics and it makes them pee out a lot. So when they pee a lot, they lose a lot of water. What happens to the blood volume? Gets smaller. When the blood volume gets smaller, what happens to the stroke volume? It gets smaller. What happens to the contractility? It gets smaller. What happens to the cardiac output? It gets smaller, and then you go back to normal. The opposite, if you're dehydrated, if you're sweating a lot, if you haven't drank water in a long time, and your blood is not full of water, the kidney is not going to be urinating, it's going to be holding urine back. It's going to be holding urine back, and then it's going to make the blood pressure go up. Are we clear? Now the third is electrolyte and acid-base balance. We talked about that, acid-base balance. Meaning if you have too much acid in your blood, the kidney is going to take the acid from the blood and give it to the urine. It's going to take acid, say, oh, there's too much acid in the blood. Let me take it from the blood and let me give it to the urine. What about the opposite? If you have too little acid now, it will do the opposite. We'll take acid from the urine and give it to the This is really important. The kidney is a mediator in the middle. Okay? The kidney is a mediator in the middle. I wish I had a yellow marker for urine, but I don't have a yellow marker. So now let's this is your kidney. Your kidney is in the middle. And here you have your blood. Okay. Then you have that's your blood. And this is your urine going out. Urine. We already said that your lungs are gonna send out carbon dioxide. So your lungs, but remember, carbon dioxide does not exist in your blood as carbon dioxide. Carbon dioxide exists in the blood as what? Very good. It exists as carbonic acid. So if that's your tissue, if that is your tissue is going to be generating carbon dioxide. When it enters into the red blood cell is going to say, I cannot take carbon dioxide. There is an enzyme inside that red blood cell who will take carbon dioxide and add water to it. And that's going to give you HCO3, carbonic acid, HCO3. What's the name of that enzyme that does that? We talked about it last time. The name of the enzyme, because you know carbon dioxide cannot go in a red blood cell. There's a little bit of carbon dioxide floating freely here. That's true. But it's like 1%. It's inefficient to rely on carbon dioxide in this form to dissolve in blood. If you want to ride into the red blood cell, you have to be converted into carbonic acid. Carbonic acid. There's an enzyme that does this job. We need an enzyme that will take carbon dioxide and water to give you carbonic acid. What's the name of that enzyme? Remember I said CAH? CAH? Remember CAH? So what does CAH stand for? Carbonic anhydrase. Carbonic anhydrase is going to convert this into carbonic acid. When we go up the lung, carbonic anhydrase now is going to point in the other direction and is going to change carbonic acid back into red blood cell, into carbon dioxide, then carbon dioxide is going to be thrown out from the lungs. So that's one way we get rid of carbon dioxide. There's another way. If there's too much carbon dioxide, carbonic anhydrase, you know, is going to combine carbon dioxide with water to give you carbonic acid and hydrogen proton. You know what's the relationship between pH and hydrogen proton. So the more hydrogen proton you get, that's going to mean your pH is going to be low. That means your carbon dioxide is going to be high. That means this is going to be acidosis. You must know this relationship. If your hydrogen proton is high, that means your pH is low. That means your carbon dioxide is high. That's acidosis. The opposite. If the hydrogen proton is low, and that will mean that pH is going to be high, which means carbon dioxide is going to be low, which means you will have alkalosis. 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 This relationship is really important. So, when there's too much carbon dioxide, is the same thing like having, nobody need to tell you that the four. One, you should know the three are happening. If anybody tells you carbon dioxide is too high, nobody can tell you at the same time acidosis, at the same time pH is low, at the same time hydrogen proton is high. They come together. Hydrogen proton is low, you should immediately register in your brain. Nobody need to tell you that. Hydrogen proton is low, pH is high, carbon dioxide is low, alkalosis. Now, let's look at the kidney. The kidney, this reaction here is really important. Where you have carbon dioxide plus water, that's going to be converted into carbonic acid and hydrogen proton. Is that clear? Who's going to remove carbon dioxide? Who's going to remove carbon dioxide? Your lungs. And who's going to remove the hydrogen proton? Your kidneys. So the kidneys are going to take the hydrogen proton. The hydrogen proton is going to be taken by the kidneys and thrown in the urine and then voided out the bladder. So the kidney is going to remove hydrogen protons. That is if we have acidosis. What if the other way around? What if we have too little carbon dioxide now? We don't have too much. We have this now. We don't have case number 1, where you had this happening. Now you don't have case number 1. Now you have case number 2. What is case number 2? Hydrogen proton is too low. So now immediately you should know pH is too high, carbon dioxide too low, alkalosis. So what do you think the lung is going to do? When you had the top one, you hyperventilated. So you removed carbon dioxide. And you peed a lot to remove hydrogen proton. But when the alkalosis, too little hydrogen proton and too little carbon dioxide, are you going to be peeing out a lot? So what's the kidney going to do? The kidney is going to hold back. Very good. The kidney is going to hold back urine. Very good. And the respiratory system is going to what? Hypoventilate. Very good. Right? Slow down the breathing. Hypoventilate. Hypoventilate. But before, the respiratory system was going to hyperventilate. And the kidney is going to increase urination, which is called diuresis. Diuresis. Increase urination. Increase urination, diuresis. This is really important. That you must know the kidney is always in the middle. The kidneys are in the middle. The kidneys are in the middle. If there's too much acid in the blood, they will urinate it out. If there's too little acid, they will hold it out. If there's too much calcium, what are they going to do to the calcium? They're going to eat the calcium out. If there's too little calcium, they're going to hold it back. If there's too much sodium, they're going to pee it out. If there's too little sodium, they're going to hold it back. If there's too much potassium in the blood, the kidneys are going to urinate it out. If there is too little potassium, the kidneys are going to hold it back. Do you see now? This urine is under the administration of your kidneys based on the metabolic demand. What do you have too much of? What do you have too little of? And obviously the kidney is doing this at the same time. If you have too much calcium, too little sodium, too much potassium, the kidney is gonna pee out a lot of calcium, at the same time hold back sodium, at the same time pee out a lot of potassium. Because the kidney, like we said, is in the middle, mediating. Do we need stuff to be thrown out? We head this direction. Do we need stuff to be thrown back? We head it to this direction. Are we clear? Are we clear? This is really, really, really important. If you read the chapter before you come, it's gonna help you a lot to understand. So read the chapter, or at least look at the slide before you come, so we can come and have a productive discussion and everybody is participating. Okay, the kidneys filter blood and excrete toxic metabolic waste. We said that. Regulate blood volume and osmolarity. Also with water. Too much water in the blood, throw it out. Too little water in the blood, hold it back. Calcium level. They are important also for making. Your kidneys make this hormone. You need to know this hormone. Calcitriol. Calcitriol. What is calcitriol important for? Reabsorbing calcium in the intestine. So when you drink milk, who's going to absorb milk from your intestine to your blood? That is calcitriol. Also, free radicals. Free radicals, those are injurious, stressful, noxious electrolytes. And in starvation, they synthesize glucose from amino acids. What is that? Synthesizing glucose from amino acids. Now, when you make glucose from lactose, is that something unusual? Making glucose from lactose. Is that unusual? No, because lactose is a carbohydrate from the milk. If you make glucose from maltose, the sugar of the oatmeal, is that surprising? It's not surprising. Is making glucose from sucrose, is that shocking? That's not shocking. You know what is shocking? Making glucose from amino acid. No, that one is shocking. And the kidney does that. So when you have no sugar in your body, and the kidneys resort to something unusual to make sugar from proteins. This is called new synthesis of glucose, or they call it gluconeogenesis. You know, Genesis, the Bible, the first book of the Bible, Genesis, the making. So the genesis of glucose, but from new sources that are not traditional. They call it gluconeogenesis. You know, neo, like the neo-Nazi? You know, the neo, so they say gluconeogenesis. It's the making of glucose from non-carbohydrate precursors. What is gluconeogenesis? Yeah.
Getting glucose from other sources other than what they like. they usually look like molecules or fructose, integrating sugar from protein.
Excellent. Sugar from amino acid. Excellent. You're correct, 100%. But why do you say better amino acid than protein?
Because amino acids is the building block.
Excellent. Very good. And protein exists on the outside in casserole, in a sandwich, but when you eat it in your body, it's no more protein, it's amino acid stored in the form of amino acid. When we need it, we bring it back, we metabolize it. When we don't need it, we break it down, we anabolize it. Anabolize it, building up. Metabolizing, breaking down. Very good, excellent, good job, very good. Okay. We said uric acid is a product of nucleic acid metabolism. And you have the blood urea nitrogen, the level of nitrogenous waste in the blood. And okay, yeah, this is really important too. Now, you have to have an understanding of there's different kinds of waste, but the nitrogenous waste is the worst of all, the most terrible of all. If you saw the picture I showed you in the beginning, urea, ammonia, creatinine, uric acid, they all have what? Nitrogen. Urea, nitrogen. Creatinine, nitrogen. Uric acid, nitrogen. So these are the ones that are very bad. Your body can tolerate a healthy range of waste. You know, nobody is 100% clean. Nobody is 100%, the blood is not 100% clean. It can be as nasty as from 10 to 20, that's it. Your body can tolerate toxic, nasty, disgusting nitrogenous waste in the level of 10 to 20 milligrams per deciliter. If you went uphill from that, you're gonna enter azotemia. 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 So this is called the blood urea nitrogen. What is BUN? BUN. BUN is blood urea nitrogen. Blood urea nitrogen is how much toxic waste nitrogen. It has to be just nitrogen. If it's 10 to 20, that's fine. If it's more than 20, that's azotemia. Azotemia is like bad number one. If it keeps on going, getting worse and worse and worse, now you're gonna move on from azotemia into uremia. Uremia. From azotemia into uremia. Is that clear? Azotemia into uremia. What is uremia? Uremia is when there is so much nitrogenous waste that this nitrogenous waste is poisoning your body and now is making four things. It's a rectangle. It has four heads. It's a four-headed beast. This uremia. Number one, diarrhea. Number two, vomiting. Number three, dyspnea. Number four, cardiac arrhythmia. So patients with kidney failure, all the time, they have too much azotemia. And some of them in a country, in a poor country, the hospital is not good. The hospital is not helping them. The machine is not, the dialysis is not good. Then they're gonna move on from azotemia into uremia. What are the four things of uremia? On the exam, they're gonna put 5 things and tell you which one of those is now in the syndrome. What's the syndrome? A syndrome is when you have many things happen. A disease is when you have one problem. A syndrome is when you have diarrhea, that's a problem. Vomiting, that's a problem. Dyspnea, that's a problem. Cardiac arrhythmia, so now that's not a disease, that's syndrome. Okay? What are the 4 clinical manifestations of uremia? Number 1, diarrhea, very good. Number 2, vomiting. Number 3, dyspnea. Dyspnea, you can't breathe well. You have this always means hard. Dysuria, you cannot urinate easily. There's pain and suffering. Dysphagia, you cannot swallow easily. Dyspnea, you cannot breathe smoothly. You're gasping, you're thirsty you're hungry for air. That is dyspnea. And cardiac arrhythmia, we talked about that. What is cardiac arrhythmia?
When your heart is not beating no more.
So when your heart is not beating no more, that is not dysrhythmia. So from the name what this mean? Dysregulation.
Everything. Not just.
It's cardiac, yeah. So arrhythmia is arrhythmia is dysregulation of the heart rhythm. We call it arrhythmia. So when your heart is not beating anymore, that's death. You're dead. But arrhythmia is not the same thing as when your heart stops. Yeah. Both are arrhythmias. So arrhythmia is a big umbrella for any time is vague. That's why you have 4 people coming in, exactly what you said. One person coming in with bradycardia, one is coming with tachycardia. Both have arrhythmia. So the ones with kidney failure, they cannot urinate. Exactly. So there's so much water in their blood, right? There's much water and much waste and toxic waste in the blood. So what does that mean? It means they will have high blood pressure because they cannot urinate. There's so much water building up. And we said so much water building up is going to increase the volume of blood, is going to cause hypertension. In addition to that, since you cannot pee, what's happening to the waste in your body? Is building up. So arrhythmia is a big vague word for dysregulation of heart rhythm. It could be too much stimulation or too little stimulation. But we have to specify. So that shows you that one patient that come with a uremia with too much heart electrical stimulation. Another one arrhythmia, too little heart stimulation. So they use hemodialysis or organ transplants in order to repair this irreparable problem. So now you see your major nitrogenous waste, ammonia, urea, uric acid. We said excretion is to separate the waste. So excretion is reserved for what? For bad things. You don't excrete anything good. You don't say, well, the pancreas was excreting insulin. No, the pancreas was secreting insulin. You say the blood, the sweat glands were excreting sweat. No, that's not true. Excreting is bad thing, but sweat is good. So we're going to now use the word secrete. The milk duct, excrete milk or secrete milk? We said excrete is for bad things. Is milk bad? Secrete, good, very good. I heard excrete somewhere. Integumentary system. So we talked about the 3 major ones: respiratory, digestive, and urinary. What about the integumentary system? Your skin. Do you not lose through the skin also? We lose water through the skin. It's called cutaneous perspiration. Cutaneous perspiration. So the sweat is containing good and bad things, but it is promoting our health and well-being. That's why it's positive. Because when the sweat comes out, it has water, it has sometimes fat and oil, it has dermacidins, it has acid mantle, it has different types of beneficial substance. But also it has, our own blood leave the sweat. Even our own blood, when we did the blood chapter 18, the blood has water, the blood has plasma, the blood has red blood cell, white blood cell, but it also has waste. So it is never perfect. So there is an excretory part of our blood. There's an excretory part of our sweat, but sweat is an overall positive thing. But this slide is just showing you the excretory portion of your sweat. But the vast majority of the sweat is for your health and well-being. Okay? Okay. Now the anatomy of the kidneys, we said that they are retroperitoneal. So if somebody has a kidney stone, kidney stone, my grandmother say that. She's a kidney stone. But we don't say kidney stone. What do we say? Renal caliculi. Renal, caliculi. Renal caliculi. So if anybody has a renal caliculi, what do they end up with? Pain in the retroperitoneal position. So retro is in the back. Peritoneum is the cavity of your abdomen. So it's in the back portion of your abdomen. You see? The kidney is like a soap, a bar soap. It's not very big, but it does great things. Does very big things. There are capsules around the kidneys. Remember we said that the lung has the visceral pleura, the parietal pleura, and fibrous capsules. What about the heart? We said the heart has visceral, epicardium, parietal. It has the pericardium. It has the parietal pericardium, the visceral pericardium, also known as the epicardium. Two zones of the renal parenchyma. You have the outer renal cortex and the inner renal medulla. Now, this urine, once it's made, originally is made where? In the glomeruli. Then the glomeruli is gonna dump the urine into the sink. You know the bathroom sink is called the minor calyx. That's the sink. Then the minor calyx is gonna drop the urine into a bigger sink known as the major calyx. Then the major calyx is gonna drop all the urine into the very big tubing that's gonna lead to the urinary bladder that's known as the major calyx. There you go. You see the minor calyx, the first sink. Then this very big one is the major calyx. Then this mostly huge part is known as the ureter. Very good. Kidneys are only 0.4% of the body weight, but they receive more than 20% of the cardiac output. That's known as the renal fraction. So the renal fraction is the fraction of your blood that is received by the kidneys. Is that cool? Do you understand? Now, the renal artery is the one that's gonna bring in this renal fraction, this blood into the kidneys. So the renal artery is gonna divide into segmental arteries that give rise to interlobar arteries. These extend up the renal column between the pyramids. Then you have the arcuate arteries. These are found over the pyramids. And then you have the cortical radiate arteries. These are up into the cortex. Then they're gonna branch into afferent arterioles, each supplying one nephron, and they lead to a ball of capillaries known as the glomerulus. Blood is drained from the glomerulus by efferent arterioles. Most efferent arterioles lead to peritubular capillaries. Some efferents lead to the vasa recta, which is a network of blood vessels within the renal medulla. Though the arcuate veins lead to the interlobar veins, which lead to the renal vein finally. So the blood comes out from the left ventricle into the aorta, from the aorta into the renal artery, then the segmental artery, which is a branch of the renal artery, then the interlobar artery, then from the interlobar artery, you extend into the arcuate arteries. These extend through the medulla. Then there is the cortical radiate arteries, and then finally the afferent arteriole that's going to lead the blood into the glomerulus. Then the glomerulus is going to filter blood into the efferent arteriole, and from the efferent arteriole, blood is going to go into the peritubular capillaries and the vasa recta. The cortical radiate vein, there's the arcuate vein and the interlobar vein, and then there's the renal vein, and we dump all the deoxygenated blood into the inferior vena cava. In the cortex, peritubular capillaries branch off of the efferent arterioles, supplying the tissue near the glomerulus, the proximal and the distal convoluted tubules. In the medulla, the efferent arterioles give rise to the vasa recta, supplying the nephron loop portion. So we have two kinds of nephron. There's a cortical nephron, then there's a juxtamedullary. Juxta means that it's close to, near the. Juxtamedullary nephron, meaning that it is close to and near the nephron. In the nephron, each kidney has about 1.2 million nephrons. This is the filtration unit. The nephron is the filtration unit that filters out the blood. So each is composed of two principal parts. There's the renal corpuscle that filters the blood plasma, and the renal tubule, that is long coiled tube that converts the filtrate into urine. The renal corpuscle consists of the glomerulus and a two-layered glomerular capsule that encloses the glomerulus. So this structure is very important for you to understand. Please inspect this structure very carefully. You have two arteries. They are too small, so they are on the end of the arteriole. So blood is going from the afferent arteriole. So which one is bringing blood in? Which one is throwing blood out? The afferent is bringing blood into the glomerulus, while the efferent with an E is the one that's taking the blood out from the kidney. So if you take a blood sample from here and a blood sample from here, which one is full of waste and which one is filtered? The efferent is filtered because this one came out, went in, got filtered, came out. Well, don't forget there is another outlet. Remember I told you, one river come in, then you split into two rivers. One river is filtered blood, and the other river is urine. Good, that's the urine. Very good. Urine, that's urine. Are we clear? So this glomerulus, what is it made up of? It is made up of this convoluted, is a capillary. So the capillaries have holes in them. Imagine you walk in and there's no holes. How is the waste gonna come out? So the capillaries are full of fenestrations and full of holes. So all the waste is gonna come out and all the waste is gonna be pushed into the proximal convoluted tubule for to be dumped into the urine. And all the good blood is gonna be returning back into the efferent portion. Are we clear? Oh God. The vascular pole is the side of the corpuscle where the afferent arteriole enters the corpuscle and the efferent arteriole leaves. So the urinary pole is the opposite side of the corpuscle where the renal tubule begins to appear. The renal or the uriniferous tubule is a duct leading away from the glomerular capsule and ending at the tip of the medullary pyramid. It is divided into 4 regions. The regions are, we said the first and the longest one is the PCT. That's your proximal convoluted tubule. Then from the proximal convoluted tubule, there is a U shape in the shape of a U. That's the nephron loop. And then there is the distal convoluted tubule, the DCT. And that is these are all parts of the these are the 3 parts of the nephron. The 4th part is called the collecting duct, which receives the fluid from many nephrons. So the collecting duct is a collector. It's a collecting duct that collects the urine from multiple different nephrons. Are we clear? Proximal convoluted tubule arises from the glomerular capsule. It is the longest and most coiled region. There's a simple cuboidal epithelium with prominent microvilli for the majority of the absorption. The nephron loop is a long U-shaped portion of the renal tubule. There's a it has a descending limb and an ascending limb. It has a thick segment that has multiple simple cuboidal epithelium. As you see here, you see the cuboidal epithelium? That's the cuboidal epithelium, and it is simple. Simple because it does not have multiple layers. You remember from AMP that tissues come in 2 varieties. Some tissues have, so you have different kinds of cells. Some cells look like a egg side up. That's known as squamous cell. Some cells look equally wide as they are long. Their length and their width are the same. What we call these cells? Cuboidal. Excellent. These are cuboidal cells. Some cells are more long compared to them being wide. So here you see the length is more than the width. What kind of cell is that? That's a columnar cell. And If you look at the squamous cuboidal columnar, how do these cells stack up? If the cells are in relationship to the basement membrane, so this is the basement membrane. So this is the basement membrane. The basement membrane. Now, let's look at the different ways cells can stack up. The law is very simple. The law says if you are one layer, meaning you have one layer squamous cells, or one layer of cuboidal cells, or one layer of columnar cells, what does that make you? Excellent. That makes you simple. If you are only one layer, like when you go out in a suburb, all the villages, they are one floor. So if you are one floor, that makes you simple. If you are one layer, that makes you simple. What if you are multiple layers? So you have multiple layers of squamous on top of each other. Multiple layers of squamous, or multiple layers of cuboidal. Multiple layers of cuboidal, or multiple layers of columnar. Multiple layers of columnar. What is that called? What is that? So that is simple is one layer. One layer. If you have multiple layers, you have multiple layers. What is that called?
Stratified.
Stratified. That's stratified. Stratified. So what is pseudo? Pseudo meaning pseudo means false or fake. Pseudo stratified meaning it's a little bit of both. So you would have some cells that are touching the basement membrane. You have some cells that are touching the basement membrane, and you have other cells that are touching. So this cell is touching the basement membrane and another cell. This cell is touching the basement membrane and another cell. So it looks like that. So what does that mean? That means the cells here, they touch two things at the same time. They touch the basement membrane and they touch another cell. They touch the basement, some cells are here and some cells are like that. So that is pseudo stratified. They are on top of each other, but they also are touching the basement membrane. These are like the goblet cells. They look like this, like a wine glass. Okay, these are pseudo stratified. So if you look at your glomeruli, so if we want to describe a tissue, we mix and match. We say squamous simple or stratified. So actually we begin with the basement membrane. We either say simple squamous, stratified squamous, stratified cuboidal, and stratified columnar. So we mix and match. Simple squamous or stratified squamous. Simple columnar or stratified columnar. Simple cuboidal or stratified cuboidal. Are we clear? That's how we describe the histology of our basement membrane. The histology of our tissue. What type of our tissue histology do we have here? Stratified or simple? Very good. Is this columnar or cuboidal? Cuboidal. So there's the U-shaped loop of Henle followed by the distal convoluted tubule. Then there's the collecting duct. The collecting duct receives urine from multiple different nephrons. So nephrons do not share proximal convoluted tubule. Each nephron has its own proximal convoluted tubule. Each nephron does not share loop of Henle. Each nephron has its own loop of Henle. No nephron shares distal convoluted tubule. No nephron shares distal convoluted tubule. They all have it. They only share the collecting duct. You know how in an apartment complex, nobody share your kitchen, nobody share your living room, but all of you share a swimming pool outside? So who is shared by everybody in the kidney? The collecting duct. The collecting duct, that because it's going to collect the urine and throws it out to the calyces. So you need to know this order here. The glomerular capsule, then the proximal convoluted tubule, then the nephron loop of Henle, then the distal convoluted tubule, then the collecting duct, then the papillary duct, then the minor calyx, then the major calyx, then the renal pelvis, then the ureter, urinary bladder, urethra, toilet. Clear? There we go. That is our afferent arteriole, glomerular capsule. You see proximal. That's why they call it convoluted, because it's always like a snake. It gets convoluted, like you see here. It's convoluted. Then you have a loop of U-shape, loop of Henle. If you look at this U shape, what do you notice? You notice that some part is really thick and some part is really thin. True or false? The really thick part is for the reabsorption of water. The thick, no. The water is being reabsorbed in the thin part, like a straw. This really thin part, the thin segment. You see here where it says thin segment, there's a thick segment. So the thick segment reabsorb water, the thick segment is gonna reabsorb glucose and proteins. Are we clear? Are we all clear? So juxtamedullary nephrons lie in the medulla, while the cortical nephron lie in the cortex. What's the difference between the cortex and the medulla? The cortex is at the roof, at the top, and the medulla is a little bit downward. So 15% of all the nephrons are pretty much juxtamedullary. They are near the medulla. But the vast majority of the nephrons are in the cortex. These are the cortical nephrons. So if you see here the juxtamedullary and cortical nephrons, so the juxtamedullary nephron is this one because it's close to the medulla, and the cortical nephron is at the top. Now, when we look at the nervous system, how the nervous system regulate urine regulation. So there is a nerve plexus. This nerve plexus is responsible for guiding the constriction of the afferent arteriole and the relaxation of the afferent arteriole. So the renal plexus is comprised of nerves and ganglia that are wrapped around each renal artery. They follow branches of the renal artery into the parenchyma of the kidneys. They issue nerve fibers to the blood vessels and the convoluted tubules of the nephron. In the renal plexus carries sympathetic innervation from the abdominal aortic plexus. So this sympathetic innervation from the abdominal aortic plexus causes stimulation that reduces glomerular blood flow and rate of urine production. So how fast and how much urine are we generating is caused by the sympathetic innervation. So they respond to falling blood pressure by stimulating the kidneys to secrete renin. So what is renin? Remember we said we're going to be talking about this a lot. The renin, angiotensin, aldosterone axis. Remember we said the renin, angiotensin, the renin, angiotensin, aldosterone system, known as ROS. What is ROS? Well, this begins, as we said, in a sensation that is caused by your kidneys. So your kidneys are going to respond to a drop in blood pressure. Drop in blood pressure is known as what? Hypotension. Excellent. Hypotension. This hypotension is going to be detected by your kidneys. The kidneys are gonna send an input signal that's gonna release renin. So that's our first target. Now we got renin. What is renin? Renin is a hormone enzyme. It's a kidney hormone enzyme. What does renin, the kidney hormone enzyme, do? Renin is going to convert, this arrow means convert, is going to convert for us something known as angiotensinogen. And please be careful with this nogen. Ogen means off. Ogen means off or inactive. Nogen means off or inactive. Ogen means off and inactive. Then angiotensin is going to be on, active. So what happened to the nogen? It was cleaved. It was broken down. So there is a process of cleavage or breakdown. So when we cleave the ogen, we end up with angiotensin. Angiotensin is now gonna travel to the lungs. This angiotensin is actually known as angiotensin 1. Angiotensin 1. The lungs have a very special enzyme there known as ACE. ACE. What does ACE stand for? ACE. A stands for angiotensin 1. C stands for converting, and E stands for enzyme. So what does angiotensin converting enzyme do? Angiotensin converting enzyme is going to convert for us. Angiotensin converting enzymes is going to be converting for us angiotensin 1, angiotensin 1 into angiotensin 2 into angiotensin 2. Are we following? Did everybody copy that down? Did everybody copy that down? So where we stop now at angiotensin 2. Angiotensin 2 is our key enzyme. It's going to have multiple different effects. One effect is that it's going to cause vasoconstriction to increase blood pressure. It's going to secrete aldosterone that's gonna reabsorb water, and that's gonna increase blood pressure. It's going to inhibit diuresis, prevent water loss in the urine, and that's gonna increase blood pressure. It's going to cause an overall increase in blood pressure because the problem was a drop in blood pressure. So we went through this whole loop here. We went through this whole loop here in order to end up in high blood pressure. Because we started with a drop in blood pressure, and now we need to increase blood pressure to repair the homeostasis. Are we clear? So this whole loop was aiming to have a terminal increase in blood pressure. A terminal increase in blood pressure. Yes.
I think that they say you have anemia cause pressure too.
Your anemia, it means if you have anemia, it depends on what kind of anemia. So there is anemia where you have sickle cell anemia.
No, it's like almost iron low.
You have what?
Iron low with negatives.
Low iron. Every female in a reproductive age who has a menstrual cycle will definitely have iron deficiency. So you need to take the multivitamin or one of the equipment that has been replenished iron. Because remember we did chapter 18 in the blood that iron is very important for hemoglobin production.
My gut has been fine. What I'm saying, my gut has been fine. What I'm saying is, why am I still like low?
Low.
That's blood pressure.
So if your blood pressure is low, that could be different thing. It may not be the anemia. Sometimes people who smoke, they don't have a drop in blood, but the bone marrow is never gonna know that. Remember we discussed that. So it's gonna be making compensatory production of red blood cell. That's gonna increase blood pressure. Why? Because there is excessive amount of red blood cell being made. But as long as anemia, anemia, your blood is actually like water, really thin. That is if you have the type of anemia because you have a failure, like a plastic anemia, where you not even make red blood cells. Okay, but why is your blood pressure low? It could be many reasons. So that I think you should see the cardiologist. Why? Because that's if your blood pressure is low, what kind of problem is that? That's cardiologist problem, that's heart disease. So you will go, you will get an EKG. So when you get an EKG, they're gonna look, maybe there's some arrhythmia problem. You never know. Maybe there is some, so you have to go get checked. Okay, this is just a checkup. Okay, so yeah. Yeah. So if you have a plastic anemia, you cannot make red blood cells. You cannot generate it, not make red blood cells. But if you have no problem making red blood cells, but you have still low cardiac output. It could be from person to person, it's different. So you have to find out, you have to get checked and see your cardiologist.
And what about another headache?
So the headache is also because sometimes you think too much. Some people don't know that. You know, like you are concerned about things and you're always thinking, that can make headache. Also, the headache could be maybe you have cholesterol. The headache may be because you have sleep apnea. Maybe, like I said, different things. So you have to go, every person, there's no one answer for all the people. So when you go get checked, you do a whole checkup in the internal medicine doctor. So the internal medicine doctor is gonna do a whole checkup to see what is wrong with your body. Okay? Any questions? Anyone have a question? This is not the first time, and it will never be the last time where we do the renin angiotensin aldosterone system. So now we look at the basic stages of urine formation. So you see, you have one entry and two rivers. We enter as one and we exit as two. We enter as the afferent arteriole and we exit as the efferent arteriole, and you have this collecting duct and going out in the urine. So the first stage of urine formation is the glomerular filtration. It creates a plasma-like filtrate of blood. Then there is a tubular reabsorption, where it removes useful solutes from the filtrate, returns them to the blood. The tubular secretion removes additional waste from the blood and adds it to the filtrate. And lastly, we conserve water. So we remove water from the urine and return it to the blood. So how many phases? You need to know that. You need to know that blood comes in, gets filtered. That's phase one. Glomerular filtration. Phase two is the tubule. Remember the proximal convoluted tubule, the loop of Henle, the nephron loop, and distal convoluted tubule. They end up reabsorbing the beneficiary stuff that was filtered. You notice everything in the urine in the beginning is not bad. So the urine in the beginning, if you take the urine a sample from here, from the top, and you take urine sample from the bottom, this is very bad. This has some good stuff in it, like some glucose, some protein, a little bit of amino acids, a little bit of electrolytes. So they all get reabsorbed. Say, wait, when the way you're going, don't be in a hurry, you want you back in blood. So we take that back from the blood. Even the blood that gets filtered, there's still some nasty metabolic waste. So we throw it back into the urine again. And then finally, we reabsorb the water, the substance of life, most important thing. So we grab the water, and now we have this concentrated, terrible urine that nobody wants. There's not supposed to be any blood in the urine because red blood cell is too big. There's not supposed to be any protein in the urine because the protein in the urine is too big to filter out through the capillary fenestrations and slits. Cannot, it's too tiny. So if it leaked out, that means there is an injury. There's some problem. Or maybe there's a kidney stone. Somebody has a kidney stone and the kidney is injuring the ureters. So now the blood is flowing out. Are we clear? Kidneys convert blood plasma to urine in 4 stages. You have glomerular filtration, tubular reabsorption, tubular secretion, water conservation. So the glomerular filtrate is the fluid in the capsular space. It is similar to the blood plasma, except that it has almost no proteins. Tubular fluids. These are fluids from the proximal convoluted tubule through the distal convoluted tubule. And these are substances that have been removed or added by tubular cells. The urine is a fluid that enters the collecting duct. It undergoes little alteration beyond this point, except for changes in water content. So the urine is the fluid that must be expelled out. So you see the slits I was talking about. This figure here is really, really important because what are we seeing here? We're seeing this is the blood vessel, and that's the capillary. Remember the fenestration, the holes in the capillary? They are too small to let a red blood cell pass through. So that shows you here the arrow is pointing back. So the arrow here is not allowing the pass because they're too big. For example, blood cells, they are too big to penetrate through. Plasma proteins, large anions, protein-bound minerals, and hormones, and any molecule more than 8 nanometers in diameter is going to bounce out because the hole is too small. And sometimes if a little bit stuff leaks out, you see these foot processes, like a foot, these are known as podocytes. These podocytes are going to block and ensure that there's no passage. Also, you must remember, who passes through that? You see the arrow now is pointing out. Who's coming out? Water, electrolytes, glucose, amino acid, fatty acid, vitamin, urea, uric acid, creatinine. So that's like a mixture of good and bad things. That's why in reabsorption, do we reabsorb creatinine? No, we excrete it in the urine. Do we reabsorb uric acid? We excrete it in the urine. Do we reabsorb urea? We secrete it in the urine. Do we reabsorb vitamins? Vitamins. Yeah, we take it back. We reabsorb vitamins. Do we reabsorb fatty acids? Yes, we need fatty acids. Do we reabsorb amino acids? Yes, we need amino acids. Do we reabsorb glucose? Yeah, we need it back. Do we reabsorb electrolytes? We need it back. Do we reabsorb water? What about if we reabsorb glucose? Why do the people with diabetes have sugar in the urine? They have so much sugar that these reabsorbing channels have reached TM. What is TM? Transport maximum. They have reached the transport maximum, the maximum capacity to reabsorb glucose. Now there's overwhelmed, too much sugar. Now they only reabsorb what they can, and the rest goes up in the air. Cannot be caught back. Clear? Glomerular filtration is a special case of capillary fluid exchange in which water and some solutes in the blood plasma pass from the capillaries of the glomerulus into the capsular space of the nephron. So in the filtration membrane, there are 3 barriers. The first one is the fenestrated endothelium of the glomerular capillaries, which is 70 to 90 nanometers. Then there's the basement membrane. So the basement membrane is made up of proteoglycan gel. It has negative charges that exclude molecules greater than 8 nanometers. Then there are filtration slits. These are podocyte cell extensions that wrap around the capillaries to form a barrier layer with 30 nanometers of filtration slit. So we talked about who gets filtered out and who gets brought back. Now, we discussed this concept that Protein must not be in the urine. But if we somehow found protein in the urine, what is that known as? Proteinuria. And if there is blood in the urine, it's not supposed to. What do we call that? Hematuria. So distance runners and swimmers often experience temporary proteinuria or hematuria. So there's prolonged strenuous exercise that reduces perfusion of the kidney. So the glomerulus is going to deteriorate under prolonged hypoxia. Filtration pressure depends on hydrostatic and osmotic pressures on each side of the filtration membrane. The blood hydrostatic pressure is high in the glomerular capillaries, and hydrostatic pressure in the capsular space is about 18 millimeters of mercury due to this high filtration rate. So you must also remember that we have a colloid osmotic pressure. So the same way hydrostatic pressure propels blood into the glomerulus, what causes, if you examine here, if you see where my mouse is, what causes this directional movement? What makes urea move from the capillary in the bloodstream into the capsular space? The osmosis, the osmotic pressure, the colloid osmotic pressure pushes these chemical substances in order to diffuse into the capsular space. So the net filtration pressure is 60 outside the capsule, but the capsule is fighting back by pulling in 18 and 32, and that is going to lead out to a net of 10 millimeters of mercury that's going to filter out. So in the positive direction, meaning that the glomerulus is pushing out 60 millimeters of mercury, but the osmotic pressure is saying 18 and 32 to be brought back. So that leads to a net of 10 millimeters of mercury that's going to get filtered out. So high blood pressure in the glomerulus makes the kidneys very vulnerable to damage because the blood pressure is moving so rapidly in the kidneys that's going to cause a damage and destruction in the kidneys. What is this? You guys hear?
Where we last left off, urine production. And remember that there are three major renal processes: filtration, reabsorption, secretion, and the fourth one we can say is excretion. Let's begin looking at urine production by firstly looking at filtration, glomerular filtration, which is the first step in urine production. So plasma volume entering the afferent arteriole is about 100%. 20% of this is filtered to the network, leaving 80% still in the arteriole, in the bloodstream. This 20%, which have just been filtered, more than 90% of it will actually be reabsorbed by the blood. And so more than 99% of the plasma return to systemic circulation from entering the afferent arteriole, meaning that we have less than 1% of the volume of the plasma actually excreted. I hope this makes sense. And an important terminology to know is filtration fraction. Filtration fraction is the amount of plasma filtered from the glomeruli into the nephron, and this is 20%. Now let's look at how the substances actually get filtered from the glomeruli into the nephron. So here I'm drawing the afferent arteriole and the efferent arteriole. The efferent arteriole coming in and the efferent arteriole going out of the bulbous capsule. Here are the glomerular capillaries, and this is the bulbous capsule. We have special cells surrounding this area known as mesenchymal cells. Mesenchymal cells contain actin, which perform contraction, and so have an important role in altering blood flow. And then we have these other cells surrounding the arterioles known as granule cells. And if you remember, they're the cells that secrete the hormone renin. And then we have the thick ascending limb, which passes in close contact with the head of the nephron. And this is because they contain special cells known as macular denser cells, which are chemoreceptors, which help balance ion, which help balance ion levels of sodium and chloride passing through. And finally, the most important thing we should know is that there are podocytes in the glomerulus. Podocytes are important in the filtration process, which is the first step in urine production. Podocytes have many feet-like projections. Let's have a look at how substances get filtered and how podocytes are important in this process by taking a cross-section of this glomerular capillary. So here we have the actual capillary. And here we have mesenchymal cells. Podocytes surround the capillaries with its many feet-like projections, like so. Remember, inside the capillary we have ions, we have red blood cells, solubles, essentially. Let's take a closer look at these membranes, and how substances get filtered. Just a quick look. The first membrane is the capillary's endothelial cells, which are fenestrated, which means that they have gaps, allowing for solids to move from the capillary into the nephron. The second layer, we have the basement membrane, where solids can still easily pass through. The outer layer, we have podocytes, feet-like projections of podocytes, foot of the podocytes, and they are spaced out, or they can be very close together. And they will have also gaps between them, allowing for filtration. The endothelial cell, the basement membrane, and the podocyte make up the group of membranes known as the filtration membrane. Now, the filtration membrane being that where there is a gap, they make a filtration slit, which means that substances can actually get filtered from the capillary into the nephron. The filtration membrane controls what type of substances moves into the nephron. They actually do not allow big molecules to move through, and they do not also allow big negatively charged molecules to pass through. Why is this? Well, let's have a look again at here we have the glomerular capillary, and we have substances within this glomerular capillary. We have negatively charged proteins, we have negatively charged ions such as chloride, we have positively charged ions such as sodium, and also we have negatively charged proteins such as alcohol. Now, the podocytes and the basement membrane are actually overall negatively charged due to proteins and carbohydrates on them, known as proteoglycans. So because of proteoglycans, podocytes and basement membranes are overall negatively charged. What does this mean? It means that positively charged molecules are absorbed more readily and easily than negatively charged molecules. For example, albumin, which can actually pass through because of its good size, doesn't pass through because it is negatively charged. And so negative repels negative. Sodium can easily pass through because it is positively charged, and so it's trapped. Chloride can actually pass through because it is very small, and even though it's negatively charged, it will pass through. However, these big negatively charged proteins, they will never pass through because for one, they are too big to pass through, and second, they are negatively charged, and so repel the negativity of the podocytes and the basement membrane, basically the glomerular capillary. Okay, so we know that substances can move from the glomerular capillary into the nephron because of these filtration slits. But what causes them to move from the glomerulus into the nephron? Well, pressure causes them to move from the glomerulus into the nephron. So let's look at filtration pressure and how it causes these substances to move from the glomerulus into the nephron. Sorry, I'm saying glomerulus and nephron at times.
Hello, my name is Adam Ferrari, Chief Executive Officer of Phoenix Energy. I look forward to you joining us at our next.
So here we have the head of the nephron above this capsule and the glomerulus capillary. After material going in and
So you may continue watching this at home, but the point that is being said here is that in our filtration, we rely on two separate mechanisms. We have chemical and we have mechanical filtration. So the blood that is coming into the glomerulus, we said that we have the afferent arteriole bringing blood into the Okay, so blood is now going to enter through the afferent arteriole and it's going to leave through the efferent arteriole. Well, there are holes here. There are holes here that allow for the passage of substance that are 8 nanometers, such as electrolytes. We discussed that you have electrolytes and you have glucose and so on. Once they get out, this is your glomerulus. And the glomerulus has foot processes. These foot processes ensure that we have two types of filtration. We have mechanical filtration, and you have chemical filtration. How do we have mechanical and chemical filtration? Mechanical filtration is based on the size of the pores, meaning if you are a red blood cell, you're so big you cannot go through those little slits, so you would be sent back. You cannot be filtered. The second thing is that we also have these podocytes. These podocytes or foot processes, so that if you try to leak out, they will block you with their heads. So these foot processes with their feet are gonna push back and block any leakage of any substance that is not supposed to. So that's mechanical. What's chemical filtration?
Based on the charge.
Exactly. That's exactly what it's based on. So you see that the basement membrane is charged, meaning that if you are positively charged, you will be repelled back into the blood. You cannot get filtered out. But if you are of an opposite charge, you will be allowed to leak out into the urine and become part of the waste. That's very important. Is that point clear? Any questions? Any questions? So you can watch that video, it's on the slide, you can watch it at home again to get a clear idea. So we will stop here and you can go on your break and work on the virtual labs and we will meet again in the laboratory where we were, that was 305 or 309? 309. We'll be at 309. There are virtual labs, and you guys be looking at the slides, tissue slides. Those tissue slides You have to look at them and you have to draw them and you have to put the magnification that you use to be able to see. Was it a 10x lens? Was it a 40x lens? And then take a photo of that and upload it to the portal. Portals are always with the date of the lab. So today is June 11th. You will see June 11th renal system lab photos. You take a photo and I'm gonna let the portal open until 2/9. If you didn't do the lab last week, you could look at those slides and draw them. You could not draw off of somebody else because they saw the slide. So you have to see the slide, draw your own photo, and then upload it, and I will accept that. Okay, so you can I'm gonna take the attendance now, and then you can take a break, and we will be there soon. Okay?